Hello?
We'll start.
Yeah, we'll start. Samantha. Okay, please.
Good afternoon, all. Today, as part of our masterclass on vascular diseases organized by Vascular Society of Kerala, we are dealing with a very important topic. Very important in the sense that it is the most common preventable cause of hospital deaths and an important cause of long-term morbidity. And we have all these diseases in the form of DVT, pulmonary embolism, post-thrombotic syndromes, SVTs, superficial venous thrombosis. And we had been taught a lot about the Virchow's triad, conditions like May-Turner syndrome, a big scenario of cases and different scores like Wells score, Caprini score, all these things. Today, we have three eminent speakers. First speaker is Dr. Tom Katur from Kottayam, assistant professor in the Department of Vascular Surgery, the Division of Vascular Surgery in the Department of General Surgery. Then we have our own secretary, VASK secretary, Dr. Vimal Aip, consultant vascular endovascular surgeon at Lourdes Hospital. And then one of the senior most members of the VSA Vascular Society of India, Dr. R. Shekhar, consultant vascular and endovascular surgeon from Kogilaban Dhirubhai Ambani Hospital, Mumbai. Each of them will be sharing some aspects of DVT, post-thrombotic syndrome, interventions, and all these things. I welcome each and everyone, the speakers, the VASK members, and our senior teachers like Professor Unikrishnan sir, Professor RC sir, and all senior members, and all delegates and participants to this VASK meet. With a short introduction, let me introduce the first speaker, Dr. Tom Katur. He has done his vascular training and is now the assistant professor in the Division of Vascular Surgery at Government Medical College, Kottayam. He'll be talking on the basics of DVT, the DVT, a silent killer. Over to Tom for your question.
Thank you, Rajesh sir. Now, I will share my screen. Just a second. Hello?
Yeah, request all to keep mute. Request all to keep mute.
Hello?
Yes, Tom.
Is my screen visible?
Yes, yes. Go to full screen.
Okay, thank you, Rajesh sir. Over the next 10 minutes, I would like to talk on why DVT is called a silent killer, the need for a thromboprophylaxis, diagnosis, and medical management of DVT. 13th October is regarded as the World Thrombosis Day in order to increase the awareness of VTE. VTE is a combination of DVT and pulmonary embolism together considered as VTE. It is considered as the #1 cause of preventable death in hospitals, and about 60% of VTE occurs during or shortly after following hospitalization. Approximately 10 million cases of VTE are reported worldwide. In US, 1 lakh to 3 lakh VTE related deaths are reported, whereas in Europe, it is 5 lakh. This is a statistics showing the combined mortality from breast cancer, AIDS, and car accident is less than that from the pulmonary embolism. Situation in India is also as common as in the West. A report from CMC Vellore states that about 18 per 10,000 admission having an incidence of DVT, but it is still highly underreported in Indian scenario. This is the data from a 10-year autopsy series, which shows about only 32% of patients who died of VTE had diagnosis of DVT in antemortem. Another study from 1989 was showing only 19% had symptoms of DVT and only 3% have objective tests to confirm the diagnosis. So this is a picture of the famous tennis player Serena Williams, who had a provoked VTE in 2011. And later in 2018, she had a recurrent episodes of DVT with pulmonary embolism while giving birth to her child Olympia. She was saying when she had a recurrent episode of DVT and pulmonary embolism, then she had shortness of breath and nurse didn't pay attention to her. And she insisted for investigation and later turned out to be a pulmonary embolism. This is the famous American journalist David Bloom, who died of a massive pulmonary embolism while he was reporting war at Iraq in 2003. Later, his widow, Melanie, joined many NGOs to raise the awareness of VTE in United States. This is the current trend and predicted projection of VTE. And they are saying by 2015 in US, the incidence will be doubled. Yes, it is preventable. But Endo study, Indian subset was showing about 53% of patients who were admitted were at risk for VTE, but only 18% received ACCP recommended prophylaxis. This is against a global average of 50%. Yes, we are using underutilization of pharmacoprophylaxis. So there are many predictive scoring systems. A Caprini score is a well-validated system with about more than 200 studies, and it consists of about 40 elements. A chart like this is available, which can be pasted to our patient's IP register, and a total score can be calculated. For an example, a 65-year-old male with CA rectum, and we are planning for an APR. His total score will be 6. So what prophylaxis you will give? The patient's score of 6 is at a high risk of developing VTE, and he needs both mechanical and pharmacological prophylaxis, and minimum duration according trials is 1 to 10. Suppose if the patient's risk factors is 9 or more, is at highest risk, and he needs a thromboprophylaxis for a minimum of 30 days, that these patients need anticoagulation even after discharge. This is famous Rudolf Virchow, who put forward the Virchow triad in 1856, but it still holds good in nowadays also. The problem with the DVT is that most are asymptomatic and clinical signs will be unreliable. But sometimes patient can present with acute symptoms like Flechnesia alba dolens or Flechnesia cerula dolens or blue leg syndrome, which can cause venous gangrene. And also we have to look out for the warning signs of pulmonary embolism in these cases. To diagnose the DVT, there is another scoring system called Wells scoring system, which gives us the pre-test probability in a symptomatic patient. It consists of 10 elements. Again, we can calculate all these symptoms of this patient. And if the score is more than 2, a patient will be in high risk of having a VTE. So if a patient is having high score, we can even start anticoagulation without a confirmation of Doppler study. Another very good investigation for screening is D-dimer. It is a fibrin degradation product, and it is having a very good negative predictive value of 99%. That means if patient's D-dimer is less than 500 in a suspected case of DVT, we can 99% say patient doesn't have a DVT. But false high values can be seen in post-surgery, trauma, pregnancy, infection, old age, and in patient with cancer. So duplex is a very reliable and sensitive investigation for diagnosing DVT. We can see dilated vein, which are non-compressible with absence of flow and respiratory physicity. A screening compression ultrasound can be performed even by a surgeons or our junior residents by using a portable USG machine, which is well available in our ICUs. We can compress with our ultrasound probe at 2 sites, at calf vein or at the femoral vein, and look for the loss of compressibility. That can be used as a screening test. Then sometimes special investigations like CT venogram may be needed, especially in a young patient with left-sided iliac DVT to rule out Meyer-Thurner syndrome, like lesions like Meyer-Thurner syndrome. This is a picture showing Meyer-Thurner syndrome in which left common iliac vein is compressed by right common iliac vein. So venography, which was an investigation, was used and was the gold standard in the previous era. Now we are using it only for the treatment planning and for the treatment. Now coming to the classification. Classification of DVT is very important because it decides upon for the treatment and prognosis of the patient. Based on the thrombus extent, we can divide DVT into proximal and distal. Distal means infrapopliteal or tibial DVT. Proximal means femoropopliteal and iliofemoral DVT with or without caval extension. Another classification is based on probable etiology. It's divided into provoked and unprovoked. We will say patient having a provoked DVT if he is having one or more provocating risk factors like hospitalization, prostate cast immobilization, surgery, trauma, etc. If we cannot find out any provocating factors like this, we will say we will label it as an unprovoked DVT. Significance is that these patients are at high risk for recurrent venous thromboembolism and they need an extended anticoagulation. Some additional consideration are needed in an old age patient with unprovoked DVT to rule out an underlying occult malignancy like routine blood investigation, imaging, tumor markers, and breast examination imaging in a case of female. In a young patient with unprovoked DVT, we can send for a thrombophilia workup. The indications are young unprovoked DVT with having a family history of VTE and a female with frequent miscarriage. A panel of blood investigations are available, which can be done at a cost of 20 to 25,000 rupees. When should you send for a sample for thrombophilia? Never in acute period and while patient is on anticoagulation. So best approach will be to send these blood sample for thrombophilia workup after stopping or anticoagulation for 2 to 3 weeks. Coming to natural history, DVT can get recanalized or it can progress and can cause pulmonary embolism, which is 9% fatal. And they can also have recurrent venous thrombosis. Then post-thrombotic syndrome, which is seen in 40% of patients with iliofemoral DVT, which adds to the morbidity of the patient. Now coming to the general principles in DVT, we should start anticoagulation therapy and the duration is based on the ACCP that we will come to that. And patient should be given good limb elevation and patient can be moderately ambulant after commencing anticoagulation. They should get good hydration. And regarding the compression garments, mixed results are there. Recent 80-10 guidelines is antithrombotic 10 guidelines is saying they are advising against the use of compression garments to prevent post-thrombotic syndrome. As we said, young patient with acute symptoms in iliofemoral DVT may benefit from thrombus extraction. So that will be dealt by Dr. Bimlaipsa later. And IVCs are not indicated routinely. They are indicated when there is an contraindications to anticoagulation. So usually anticoagulations are started with one of the following. If you are using an unfractionated heparin, we have to give a bolus dose of heparin 80 units per kg, then followed by an infusion at a rate of 18 units per kg per hour. And we should aim for an APTT of 46 to 70 within 24 hours. Otherwise, patient is at a risk for recurrent and many other complications. And if you are using LMWH, an enoxaparin of 1 mg per kg per dose BD, or if it is a fondaparin of 7.5 mg OD subcutaneously. Vitamin K antagonists like warfarin and acetylene are still commonly used in our scenario. We have to bridge with the parenteral heparin for 5 to 7 days until INR is more than 2. Ideally, we have to, even if INR is become more than 2, we have to continue heparin for at least 5 days. The warfarin, we need to have a frequent INR monitoring and titrate the dose according to that. And it is having plenty of drug and food interaction. And we should never start warfarin and before heparin and should always started after starting heparin. Why? Because while giving the warfarin, there is a transient phase of hypercoagulability because a natural anticoagulant protein C gets depleted first and patient can have warfarin-induced skin necrosis. Then came NOVAC or DOVAC. NOVAC is novel oral anticoagulant, or also we can call newer oral anticoagulant, or direct oral anticoagulant. They are called direct because they are directly acting on these clotting factors. The most commonly used ones are rivaroxaban, which is a direct factor 10A inhibitor, and it is given at a dose of 15 mg BD for 3 weeks, followed by 20 mg OD. Then another one is dabigatran, which is a direct thrombin inhibitor given at a dose of 150 mg BD. The advantage with NOVACs are they can be given orally, and it's having a rapid action, and there is no need for bridging for rivaroxaban. But in a case of VTE, dabigatran need a short bridging with heparin, and they have a reliable pharmacology. No need for testing for PTI, and our patient needs frequent visit, etc. The problems are, one was its high cost, but it is coming down nowadays, and the availability of antidote in the Indian scenario. And it is also not approved to use in a case of CKD patients. So when should you give a DOAC? This is currently the drug of choice according to the ACCP guideline and most of the guidelines. Your patient should be adherent. He should be compliant with your treatment. And if the patient have a poor INR control with other oral anticoagulant agents, and patient should have a good renal and hepatic function. So coming to the duration of treatment, as we discussed earlier, if patient is having a provoked DVT, anticoagulant should be given long term. That means we have to give it for 3 months. If patient is having unprovoked DVT, we have to give the treatment for indefinite, and they are saying not definite scheduled stop is advised. That means if it is an unprovoked DVT, they need extended anticoagulation. And also if it is a provoked DVT and risk factors are still persisting, like a malignancy, we have to continue. We have to give an extended treatment. Then segment-wise treatment, distal DVT in tibial vein can be kept in surveillance, or you have to treat it if there is still risk is persisting, patient having high elevated D-dimer, previous history of VTE, high thrombus burden, and patient having malignancy. Femoropopliteal DVT usually do well with anticoagulation alone. Coming to iliofemoral DVT, it is the most symptomatic form of acute DVT, and incidence of PTS post-thrombotic risk is high. So we have to consider early thrombus removal in these cases. The OP basis treatment is feasible now with the introduction of DOAC in stable patients. So this is the 10th ACCP guideline, anti-thrombotic guidelines of ACCP. If patient is having a proximal DVT and it is provoked, total duration is 3 months, and drug of choice is DOACs more than vitamin A. If an isolated distal DVT, we have to keep the patient in surveillance or treat the patient according to indication we discussed. If it is a first episode that is unprovoked, extended therapy should be given with no scheduled stop date. And if patient is having a VTV, venous thromboembolism with active cancer, we have to give an extended therapy, and preferred drug is LMWH, low molecular weight heparin. So summarizing, VT is not uncommon and its incidence is on the rise. Prevention is better than cure. DOACs are the first line agent as of now. Outpatient treatment of VT is feasible in selected stable patient. Generally recommended treatment duration is 3 months and may be extended in selective indications. Post-thrombotic risk is high in iliofemoral DVT, and consider various thrombus removal techniques. So we should open our eyes to thrombosis. Thank you.
Thank you, Tom. It was a brilliant talk. Rajesh sir, with your permission, shall I announce the quiz winners of the last session?
Yes, yes.
Yeah. So, just share the- right. So, the previous session was on varicose veins 2 weeks back. The prize winners are Dr. Swayambhu Raja, who's a MS resident at Amrita Institute of Medical Sciences, and Dr. Joinisi, who is a DNB resident at Lourdes Hospital, Kochi. So congratulations to the prize winners. They both receive rupees 2,500 each. So we'll also post the quiz for this session in the chat box. I request and encourage all the attendees to kindly attempt the quiz and have a chance at winning the prize. Thank you. Over to you, Rajesh.
Yeah, Dr. Tom, that's an excellent presentation on the basics of DVT. We will take the questions in the end, isn't it?
Yes.
Yeah. So we'll go straight to the next topic by Dr. Vimal Aip, our own Secretary VASK, is a consultant vascular and endovascular surgeon at Lourdes Hospital, Kochi, on the interventions in acute DVT beyond simple anticoagulation. Over to you, Vimal.
Thank you, Rajesh, for the kind introduction. Is my screen visible?
Yes, yes.
Hope I'm audible too. Okay. Good evening, one and all. Thank you, Rajesh and Siddharth, for the introduction and invitation for the speech and for the lecture. And thank you, Tom, for making the topic very simple and crisp for a wonderful presentation. Probably I have not have heard updated guidelines of this simplicity in the recent past about DVT. Over to my topic per se is actually VTE, what extra or anticoagulation we have with current evidence. So what is venous thromboembolism? Venous thromboembolism by definition is something which encompasses both pulmonary embolism and proximal DVT. It could be either one of them or with the presence of both, mean concurrent DVT with pulmonary embolism. So you can say that a patient with proximal DVT as a case of venous thromboembolism without pulmonary embolism too. Now the conventional treatment has been elaborated, and all of you probably have understood what exactly you mean by initial phase treatment of DVT. Now, as you all know that the immediate complications and late sequelae of DVT are one, pulmonary embolism, and the late sequelae being post-thrombotic syndrome, which is a nightmare for any surgeon who have faced this scenario, and the chronic thrombotic pulmonary hypertension, which we rarely come across, probably by the pulmonologists and the cardiologists who see these patients. Now, approximately 80% of symptomatic DVT of lower limb are proximal according to the studies. And of these patients, nearly 50% of them develop chronic complications and PTS, nearly 50%. And of these 50%, another half will develop severe PTS or post-thrombotic syndrome. So in summary, 1 out of 4 proximal DVT, that is iliofemoral DVT patients, are at risk of impaired quality of life and functional disability. Now, why over anticoagulation you should think of thrombus removal? You all know that heparin doesn't attack a clot. It merely prevents formation of new clot or its propagation. So how is this thrombus actually removed, or how does thrombus resolve with heparinization? It's actually the body's natural fibrinolytic mechanism taking the upper hand and heparin preventing the propagation of thrombus that this clot is lysed when a DVT occurs. And this takes a long time to happen, the fibrinolytic process. So when the clot burden is very high in iliofemoral DVT or vena cava DVT, you have to have a fast resolution of DVT or a thrombus removal to have a good result. Now the treatment goals in DVT or proximal DVT are: one is prevention of pulmonary embolism at any cost, provision of early symptom relief in the form of resolution of edema and prevention of progression to venous gangrene, and of course prevention of post-thrombotic syndrome. Now, with this thought, people have very often the post-thrombotic syndrome scenario did not come into thought process, or people didn't think of those things when in the early 1950s, because the problem was pulmonary embolism, addressal of pulmonary embolism, and prevention of loss of limb due to venous gangrene. So people thought of embolectomy and heparinization, which didn't prove very good because of the flow restoration was not good enough. And systemic thrombolysis was introduced with the problems with bleeding and intracranial hemorrhage coming up when a large dose thrombolysis is given. Surgical venous thrombectomy initially found good results, but over time what happened with us venous stasis in these diseased veins, they never worked well or long. And the surgery for venous thrombectomy, especially in an iliac segment, is with a lot of blood loss and a long procedure. So the patency and the keeping the patency on for a longer time was a problem. People even tried augmenting this flow with a AV fistula creation from the nearby femoral artery or the branch, major branch, which also didn't stay for long. Now, Semba and Dake was the first people who actually revolutionized this procedure of introducing a catheter and aspirating a thrombus, which actually paved the way for further evolution of interventions in major DVT. Now, one particular name to mention was Vedantam in 2002, showed that adding mechanical adjuncts to removal of clots to thrombolysis can produce good results in the long term. Now, we are dealing with mainly with iliofemoral DVT because the treatment of a distal DVT and a femoral popliteal DVT is relatively clear that it requires only anticoagulation. When you have an iliofemoral DVT, the amount of clot or the clot burden is so high that you have to think of something like thrombolysis and or mechanical removal. Now, as I already told, systemic thrombolysis has got more bleeding complications because the amount of thrombolytic agent which has to reach the clot and attack the clot has to be very high that it is prone to produce fatal bleeding complications. So people thought of a more targeted therapy with lesser systemic complications, whereby a catheter is introduced in the clot and a lesser and a more specific agent is introduced into the clot for a longer time, like an infusion, and the bleeding complications are found to be less. So that is how flow-directed and catheter-directed thrombectomy came in. Flow-directed thrombectomy is where you infuse the lytic agent through a pedal vein or a venous vein, probably direct with the intent of directing it to the clot. But the problem was that with the injury effect, the clot is bypassed and the vein, the lytic agent prefers to go through the ECA channel. Then surgeons tried or interventionalists tried what is known as a catheter-directed thrombectomy, wherein you introduce a catheter through a deeper vein and the multi-hole catheter is positioned into the clot and lytic agents are infused over a period of time into the clot. Pharmacological thrombolytic agents are introduced through this direct delivery catheters to facilitate thrombolysis. Now, later in the period, mechanical thrombolysis also was added to this pharmacological means so that the efficacy of thrombolysis was augmented by mechanical removal of the clots. Various techniques like rotational thrombectomy, rheolytic thrombectomy, ultrasound-assisted thrombectomy, all are available, but the expense at the cost of a huge financial load to the patient with these modern devices. We also have a simple technique of using an aspiration syringe and a catheter, trying to mechanically remove this clot, which is a very simple technique which will demonstrate if time allows. Now, what does literature say about the results of interventions in proximal DVT? Adjunct catheter-directed thrombectomy, thrombolysis plus anticoagulation therapy is an acceptable technique in initial treatment strategy, as anticoagulant therapy fails to prevent PTS, leading to significant disability, quality of life impairment, and socioeconomic costs, especially when the patient is not compliant to stocking. This was a thought process early 2000s, but recent studies have shown that the incidence of PTS has not decreased significantly with addition of this technique, but definitely the severity of post-thrombotic syndrome has come down. So unlike a femoropopliteal thrombosed vein, the thrombosed iliac vein rarely recanalizes completely by endogenous process and hence results in a significant ambulatory venous pressure. So it is self-explanatory that treatment strategies that feature early thrombus removal may prevent PTS, thereby eliminating upstream venous obstruction, preserving the valvular function, and maintaining late venous patency. Catheter-directed thrombolysis has a potential advantage to prevent PTS and offer distinct advantages compared to surgical venous thrombectomy, systemic lysis, and anticoagulation alone, according to early studies. And the advantage of this technique is that it requires only one puncture. It is image-guided or ultrasound-guided. It is successful in more than 90% of the patients. You don't require any general anesthesia in simple thrombolysis and pharmacological or pharmacomechanical thrombolysis. No surgical wounds are created, and the patient usually recovers fast, and there is rapid resolution of edema. Now, you all know that we have already discussed that systemic lysis produce so much of bleeding. And when there is a higher intrathrombus concentration of the drug delivered, the delivery is more effective and you require lesser dose. You have had the conventional thrombolytic agents like the streptokinase and urokinase, which were initially used, the streptokinase with its allergic manifestations initially. Now you have recombinant streptokinase available. Urokinase was used more often because of these reasons. And now you have the more fibrin-specific agents, which are the tissue plasminogen activators, which include the alteplase, retiplase, and the tenecteplase. So these agents have a short half-life, as well as they are very fibrin-specific. That means they act and they have high affinity to the clot, and the potential action at the site of clot is higher compared to the older agents. Now, when you do a catheter-directed thrombolysis, you are actually doing lysis by seeing the vein, by injecting contrast into the vein. So you do a follow-up venogram after or during the procedure of lysis intermittently, and any upstream obstruction, remaining clot can be visualized, and the need for an extended anticoagulation, extended lysis, or adding a mechanical procedure can be visualized by fluoroscopy. That is another definite advantage of catheter-directed thrombolysis. Now, definitely disadvantage of thrombolysis include increased bleeding risk, which is actually a contraindication, and the need for, and also during this manipulation of this thrombus, there is a small risk of pulmonary embolism, which can be fatal. Now, for postgraduates who are interested, or surgeons who are interested in knowing more about DVT interventions and the results, 3 landmark trials have been done. That is a CAVEN trial from Oslo, Norway, the ATTRACT trial by the NHS, and the CAVA trial by the Dutch. All these two, I don't want to go through each of them, but all these trials had its own flaws because the number of participants were limited. They were randomized trials, but ultimate results have not been authenticated to extend it to adding catheter-directed thrombolysis or telling that catheter-directed thrombolysis definitely is the way ahead to prevent PTS. All these trials say that definitely PTS severity is less. The intensity of symptoms and the resolution of symptoms are less. And especially in a patient with a threatened venous gangrene or a phlegmasia cerulear dolens, catheter or pharmacomechanical with pharmacomechanical thrombolysis definitely is a way to go ahead. So you can see that there is immediate restoration of patency and resolution of symptoms, preservation of valve function, because what is actually told theoretically is that if a thrombus remains for more than 90 days in a vein, the valve function is completely destroyed. So thrombolysis also lowers the risk of venous hypertension, which is a culprit in PTS. Reduction of recurrent DVT is also seen when there is a complete or a near complete resolution of DVT and the endothelial function is restored. Lesser likelihood of PTS, and definitely unmasking of a proximal vein stenosis or occlusion, which could have been a reason for precipitation of the DVT and also could probably lead to severity of PTS later. So just sharing, if time permits, how we actually do a catheter-directed thrombolysis in the Indian scenario where we don't have expensive hardware to shove it onto our patients. We confirm the presence of DVT, and then using our ultrasound, we puncture the distal vein, preferably the popliteal vein if possible. Very often it's a difficult technique because popliteal vein, the limbus edematous and popliteal vein is quite deep and you have the nerves covering the popliteal vein. Very often we have seen that we have found difficulty in access. We might go for a lower thigh access, or even sometimes we can get into a short saphenous vein and then guide your catheter into the popliteal vein. So any of these vein can be used using a Seldinger technique. The access is taken, a hydrophilic wide guide wire is introduced, and a sheath for access into the vessel is introduced over the wire. Now we first do a venogram and confirm the presence of clot, confirm that we are inside the vein, and define the extent of the disease. So that's a technique going on. Usually the patient is supine with the calf exposed and the ultrasound guide access into the popliteal vein. Now, once we get the access and you do a venogram by injecting contrast under fluoroscopy, we plan for an infusion of thrombolytic agent. We can go either way. We can have either do a pharmacological lysis over 16 to 24 hours, maximum of 48 hours, and see the result of your thrombolysis. This thrombolysis is done actually by introducing a multi-hole infusion catheter into the vein, and this is positioned into the clot, and the infusion goes on in a monitored fashion. Now the bolus and the continuous infusion and the check venogram is done after 6 to 12 hours. Now, once you complete the infusion after 12 hours, you take the patient back to the cath lab, do a venogram to know the completion of thrombolysis and any residual clots remaining and any residual obstruction upstream, which I'll demonstrate in the video. So you exchange the sheath, which is a smaller one, to a larger sheath, which is nearly 8 French or 10 French, to mechanically to introduce what is known as a catheter of larger caliber, to which you connect a large syringe and aspirate this clot out. So that's a process of clot aspiration, and you get all the clot, maximum clot is aspirated out of this. So once you clear all the clots in the iliofemoral system, residual stenosis upstream, like what Tom mentioned, like the May-Turner syndrome, can be visualized, which Dr. Shekhar, I'm sure, will be demonstrating with in his session. So I'll just demonstrate a small video of a patient. Sorry for that. Is my screen visible?
No video seen.
Still the PowerPoint.
Screen is
There's no
visible. I'll
No
pause.
video, no video. The PowerPoint is there.
Can you see the video?
No, sir.
No.
I think you can unshare this PowerPoint one, stop sharing, and then share your screen. There's a separate option.
Just a second. Visible now?
Yes.
Yes.
That's a video of a patient with acute DVT on the left side. We have taken an access as described in that picture with a popliteal vein puncture and you can see a sheath going in the popliteal vein, very narrow, 5 French sheath. And what we do is we do a venogram. And we can see that all this contrast is not uniformly going up. These are all filling defect in the femoral vein. When you reach the femoral head, you can see that there is almost complete occlusion with a little bit of collateralization. These are all tributaries finding new channels, and hardly any iliac vein seen there. So we have taken a multi-hole infusion catheter up to the iliac vein and taken an injection once more to better visualize the iliac vein. You can see that there is a large amount of clot, filling defect again filling that, and the vein is actually crossing over through tributaries of the pelvic plexus opposite to the opposite normal iliac vein and into the IVC. You can see that. Now, what we did was we infused urokinase. This was one of my first patients few years back. So we infused urokinase over 16 hours in a monitored setting in ICU with monitoring of fibrinogen, APTT, and 4th hourly HB and platelet count. And after that, patient was taken back into, patient also had concurrent heparin infusion to maintain APTT at 1.5 times the normal through the sheath. And this was a picture wherein you had residual clots here and there. You can see this clot, but majority of the iliofemoral system is patent. But when you see here, you can see that iliac vein, these are filling defects depicting clots. And then you can see that there is no iliac vein at the common iliac confluence and to the confluence of the IGC. So this is a left iliac vein. That's a way, the view from behind of the patient. And the IVC is somewhere here and the vein is not visualized. But if you look carefully, you can see some streaming of blood or contrast here into the IVC. So vein is, the blood is finding its channels through new tributaries or collaterals into the IVC. Now the problem here is we have unmasked a lesion which was pre-existing in this patient in the form of MA Turner lesion, which will be elucidated by Dr. Shekhar. Now, we have taken the patient supine after 12 more hours of anticoagulation, cleared all the clots below. And for ease of access and preventing a popliteal bleed, I have taken a femoral puncture. So the patient is supine and the left femoral puncture is accessed. Now that's a DSA picture. And you can see that there is a huge filling defect in the common iliac vein, and small channels around, showing that it's a chronic process upstream. So that's something classical of May-Turner syndrome. We cross a wire with difficulty. Usually we use what is known as a stiff wire to cross this lesion because it requires huge support for passing larger devices, and tighter lesions need to be crossed like that. Now what we did next was we confirmed the position of the catheter in the IVC after crossing that. And probably that sequence is not right. Next, what we did was this is what is known as a mechanical thrombectomy. We connect a syringe to 20 or 50 cc syringe to a 8 French guiding catheter, diagnostic catheter rather, and we mechanically try to aspirate the clot. The clots are aspirated, and you can see that the chronic clots are cleared off at that region. But comparing to the opposite side, the iliac vein is very narrow. So we can see that there is something compressing the vein here. So that is classical of a May-Turner syndrome. Now that's a DSA picture confirming the planning the length, and we do a venoplasty using a high pressure balloon, and then the lesion is opened up, and then it's followed up by stent, and that's a wall stent. That's a stainless steel stent going in, opening up the left iliac venous system. I'll go back to the presentation for a second. Sorry for that. Am I visible?
Yes.
So, we have to stop here. So once we do a venogram and confirm and correct the lesion, we continue parenteral or anticoagulation. Patient is ambulated early. Active limb exercises are promoted. Ankle exercise are promoted. And stockings are worn. I would rather add to what Tom told in the latest guidelines about compression stocking is that compression stockings, latest studies quote that compression stockings doesn't prevent a post-thrombotic syndrome developing, but definitely compression stockings are indicated to relieve symptoms of edema and especially in the initial phase of DVT, they are definitely indicated. Now, I'm not going into detail for want of time into the trials as such. In conclusion, catheter-directed thrombolysis and pharmacomechanical directed thrombolysis has a definite role to play in iliofemoral DVT in a younger patient, especially who is a good high-risk patient with no contraindication for anticoagulation and with severe symptoms. Definitely, this patient should be considered for interventional thrombolytic techniques. Definitely, patient selection and availability of expertise are crucial. Benefits of the procedure has to be weighed over the risk of bleeding. More RCTs are definitely awaited to establish solid evidence for these techniques. Thank you. Over to Rajesh.
Yeah, thank you, Vimal. That's a great presentation on the basics of dealing with intervention in DVT, venous thromboembolism. Basically, the selection of patient is what is to be emphasized, and we all appreciate that. Next, we go to Dr. R. Shekhar. He is the consultant vascular and endovascular surgeon at Kogilaben Dhirubhai Ambani Hospital, Mumbai. He is talking on post-thrombotic syndrome and the role of iliac vein interventions. And we all used to hear from him on a lot of newer agents, recent advances in vascular surgery throughout from him. We expect a lot of newer gadgets in this talk. Over to you, sir. Shekhar.
Good evening, friends. Thank you for having me for this session. Can you see my first slide?
Yes, sir.
Okay, so I'll talk you through the next couple of minutes on post-thrombotic syndrome and the iliac vein interventions. What I will discuss will be purely regarding the iliac veins that Dr. Vimal has shown you. What we'll not discuss is about the other issue with post-thrombotic syndrome and secondary varicose veins. I think that's a totally different topic, which I'll not be touching. So let us put the basic question: what might happen if you just give anticoagulants and don't do any interventions for a proximal DVT? So what would happen if you just do that? And this is something we see quite often, that patients are put on just anticoagulants and no intervention is suggested for a proximal DVT. And Dr. Vimal has told you proximal DVTs, generally we refer to an iliofemoral DVT, meaning that the clot has gone beyond the inguinal ligament into the external or the common iliac vein, sometimes into the IVC. So what will happen if you just give anticoagulants? Now, to understand that, you must understand basically the mechanics of venous drainage. If you see the picture on the left of your screen, you see that the nature has made such a beautiful kind of a one-way traffic of valves, so that blood can go only in one direction, that is below upwards. When it tries to come back, the valves actually they prevent the blood from coming back. You can see, and the calf pump then actually functions in an efficient way, so that blood is almost always unidirectional. There's very little blood coming back into the leg. Now, in the next picture, if you see what happens when you get DVT. When you get a clot, the first areas where the clot actually settles are the shelves, like the shelf-like structures. Those are the valves of the vein. And how do these clots actually clear? As Dr. Vimal has rightly put it, heparin doesn't actually dissolve the clot. It just merely prevents the propagation of the clot. So when you're giving a patient anticoagulants, you're preventing the clot from increasing. What actually removes the clots is the body's own fibrinolytic system. Now, the problem is that the body's own fibrinolytic system with all its enzymes and chemicals really doesn't differentiate very distinctly between what is clot and what is valve tissue. So whatever is in sight actually gets dissolved, and the net result is actually damaged valves. And you can see in this, this demonstrates to you what exactly happens when you get a chronic venous hypertension secondary to DVT, where the valves get damaged. And so every time the patient's calf muscles squeeze, some blood goes up, but some blood also goes back into the ankle. And so the leg starts swelling, and you get the typical signs and symptoms of venous insufficiency. The other thing that happens when you get clots is that we assume that the body's own fibrinolytic system is very efficient. So when you start with, your clots actually look like this kind of jelly-like material. But instead of actually getting lysed, it may form what is called an organized cellular thrombus. And so over a period of couple of weeks, what actually starts off as a jelly lands up being a cement-like kind of caked up material, which causes an inflammation and totally fires off the vein, occluding it totally with a hard cellular thrombus. And when you get this kind of unfortunate situation, in the long run, you start seeing in your OPD patients like these with severe pigmentation, deformities in the leg, and the chronic venous ulcers, and a miserable set of patients. So this is what actually happens. The other scenario that you might get is a typical, I've shown you a case that I saw a few months back, where you have this 45-year-old male. He gives a distinct history of acute onset leg swelling 3 years ago, treated with hospitalization, anticoagulants, went home in 2 weeks, has been on a warfarin for the last 3 years. And now he's come to the clinic for the treatment of, basically he's come for these varicose veins, right? And somebody has suggested to him that you need to treat these varicose veins with a laser or whatever. And his legs are swollen, he's not very convinced. So he comes with, this is where you should not fall into the trap. You need to properly evaluate the patient, because you can see the kind of disparity in the diameter of the leg and these secondary varicose veins. The last thing you should be actually jumping into is doing a varicose vein surgery for these, because I'll tell you in my next slide what actually is the real situation in this patient. When you did a venogram, you will see that the iliac vein is blocked, right? So he had a cellular thrombus in the iliac vein, which is packed off his iliac vein. There is what you call an outflow obstruction, and merely removing the varicose veins in that patient would have caused a very disgruntled gentleman. So coming back to a practical situation, when would you actually suspect that this patient has an iliac vein issue? Typically, we see that if the patient has a non-healing ankle ulcer, commonly but not necessarily in the left leg, there are signs of venous insufficiency which are disproportionate to what you find on your color Doppler or your duplex. So the superficial reflux is there, but it's not as severe as what you see with your eyes in terms of a clinical signs of severe venous insufficiency, a lot of pigmentation and large ulcer. That somehow doesn't seem to tally with your color Doppler findings. Typically a history, if the patient says he has bursting pain on prolonged standing, and many of our patients would actually come to us with history of multiple varicose vein surgeries. So in these patients, if you're having multiple surgeries, still have an unsatisfied patient, you should suspect possibly this guy's iliac vein has an issue, it's probably blocked or whatever, and that he at least needs an evaluation of his iliac vein. These are the subset of patients. When you see patients like this, large ulcers, but with a lot of pigmentation, right? So these are quite severe, and not very often would you see so much of pigmentation and signs of venous insufficiency when it's merely a superficial venous system which is incriminated. This is the time where you should have at least at the back of your mind about something going wrong with the iliac veins. So the preliminary investigation that very often is prescribed is either a CT venogram of the IVC and iliac veins, or some people would say, no, CT is not good, and MR venogram is what is actually accurate, and it gives us all the information, all the information. But the pitfalls of CT MRI, one, it's well documented that it has a very high false positive and false negative. False positive meaning that it says there is a compression, there is some issue with your iliac vein, but in reality it's not there. And false negative meaning that it says all is well, there is nothing, but actually there is a lot which is a problem. Secondly, it just adds to the cost. If you have to do some kind of treatment, then you need to do a procedure. So it just adds to the cost without actually contributing. And of course, in an MRI, a lot of our patients would be scared of getting into the gantry due to claustrophobia. So what is generally the approach that we usually follow when we suspect an iliac vein problem is what has been described by Dr. Vimal very elegantly, is we do an ascending venogram. As he has very correctly said, it just requires a little bit of local anesthesia, and almost always we go through the popliteal vein. So most of the time our patient would be prone, and we put in a small catheter into the popliteal vein. And then once you do a venogram, there are a couple of scenarios that you could find. One, you can see on your screen 2 pictures, where as the contrast travels upwards towards the pelvis, you find in both the pictures, the iliac vein is choked up, and there is nothing going beyond the iliac vein to some point, and you can see a lot of collaterals. This is typical of an iliac vein obstruction. This is one scenario. This is another scenario where you see the iliac vein in its entirety. There are no collaterals, but one should get this thought out of one's mind that just because there are no collaterals doesn't mean there is an obstruction. You can see there are 3 different kind of pictures that are shown on your screen. To the left, you can see there is a definite narrowing, which you can see in your screen. In the middle picture, you see that there may or may not be, it's not that great on a venogram, but you can see there are 2 areas which are compressed or are slightly narrow. When you see on the left side 2 areas which are slightly narrow, you would suspect something about which I'll talk in my later slides. On the right, you can see there is again a venogram has been done, and you really don't know whether this is actually an obstruction or it's a normal vein or what it is, whether you should do anything about it or not. So these are the issues that you might come across when you do an ascending venogram. I think it's prudent at this point to talk a little about May-Thurner syndrome, which has been briefly mentioned by the previous speakers. Now, as you can see, the picture on the right of your screen, this is the normal disposition of the relationship between the aorta and the IVC terminal part, as well as the iliac arteries and the iliac vein. Now, there are 4 areas which are encircled on your picture. Now, these are the 4 areas where there is a potential for a compression of the vein. And, due to repeated, this could be a normal disposition. This is actually a normal disposition and arrangement in all patients. And what is proposed is that by repeated hammering of the artery over the vein, there is an area of fibrosis that develops at that point of contact. And the 4 areas that I've circled, any one or more of these areas may ultimately become narrow and give rise to symptoms of venous compression, venous narrowing. And I'll tell you why that is relevant to know, why we are talking so much about venous narrowing. I'll let you know in a couple of minutes now. Now, when you see a narrowing in the iliac vein, what is classically described and has been shown by Dr. Vimal very nicely in his slide is this image. And if you closely watch this while I play this video, you can see what is called a beautiful wasting, right? So there is a kind of a dumbbell kind of picture. There is a swelling at the top, swelling at the bottom, and there is a tight narrowing at the bottom. Now, when you see this, you feel thrilled. Yes, your diagnosis is right. There is actually a venous obstruction, but this may not apply in all situations. If you get such a classical thing, then it's great, and you know that your diagnosis is right, and you can put in your stents or whatever and solve the problem. But this might not always be the case in your patient. And why is that? Because if you look at data, you can see, I'll just take you through the next couple of slides to show you why a venography is not alone is not accurate. If you see right from the 50s onwards, this fact was recognized that, if you see Cockett's studies, it says that, in up to 50% of cases, you might actually miss it by merely doing a venogram. There are other studies which tells you that venography alone is not sensitive because it's just a two-dimensional thing and you need to actually have a, more kind of a cross-sectional image, which you don't get on a venogram. And of course, there are issues where it's probably naive to just think that when you think of an iliac vein, which is narrow, it's just one compression. It might be something more than that. There may be transmural fibrosis, there may be webs or other issues, which you might not see on merely doing a simple venogram. If you look at this, and these are some of the data by some of our own, Indians who have gone abroad and done well for themselves and have been a source of great knowledge for those of us who are getting into vascular management. And if you see this data, it's pretty startling that it says that if you just do a venography, you miss a lesion completely in about 25% of patients. The site of maximum stenosis is incorrect in about 67% of patients. And the actual degree of stenosis is underestimated in about 69% of patients. So now that is pretty high, even by our liberal standards. So what do we do then to, okay, if we have our issues with costs and infrastructure, but how do we improve ourselves and look to the future to do better than what we are doing already? So the next thing that has come into the picture is what you call an IVUS. An IVUS is an intravascular ultrasound. For those of you who are into general surgery, or GI surgery, that the EUS is an established, the endo ultrasound is an established modality for certain types of tumors, especially in the pancreas. So similarly, we have something called an endovascular ultrasound. It's just like a small catheter, which I'll show you a picture, which is put over a wire into the vein. And with that catheter, you can actually visualize. I'll show you very briefly the pictures of, you can see on your screen, the pictures of this. And you can see it's a very small catheter. It's smaller than probably a flexible cystoscope. It goes through a 6 French sheath. So it's a pretty small thing. You see it's got markings. And so you can not only measure, you can not only visualize, but also measure the length of your obstructions. And if you want to see the real time, you can see how small the catheter is. It's just a small chip at the tip of this catheter. And once it's put into the popliteal vein and into the iliac vein, you can actually visualize the vein from the inside, like an endoscope of the vein. And you can beautifully not only visualize the narrowing of the vein, but you can calibrate it. You can actually calculate the computer actually helps you to actually tell you how much of narrowing there is, what the length of narrowing, how much of actual area reduction there is in that area of narrowing. And it helps you to plan your further management. So that is something which is fantastic. It's a technology which has been around overseas for quite a while. It's coming into India. We have been doing it. There are issues, as you can see on your screen. The positives, of course, are that you can, once you have done your catheter-directed procedures, you can actually see whether there is any bit and pieces of thrombus left. It tells you what are the dimensions of the narrowing so that you can put in a stent. It tells you how long a stent needs to be put, which is the upper border, which is the lower border, lower extent of the stent. And after you deploy the stent, you can evaluate if the stent has been applied properly or not. But the negatives are, one is, of course, it adds to the cost, which is a big issue in our country. Accessibility. So very often, we still don't have access to IVUS in many of our centers. And of course, it requires a certain amount of training and it requires an expertise like all, high-tech equipment. It also has a negative predictive value. And I added this slide because just yesterday we did a case and I'd just like to share with you. If you see this leg of this lady, see the kind of large ulcer here. She comes with a Doppler report which says there is a refluxing SFJ, GSV, perforators, but she's had an ulcer for more than 15 years. And you see the leg is typically severe CVI, champagne bottle appearance. She's had a spinal surgery, leg swelling, all typically pointing to probably a post-thrombotic leg. And so we said, before we jump into doing a venous ablation, let us have a look at her iliac veins. And when we did the venogram, you can see the left leg and right leg. You can see even without, even in an untrained eye, you can see that this appears that it's a kind of a stenosis in the vein, and probably would require a stent to flatten it out. Now, next thing we do is an IVUS, and the IVUS clearly showed us that the vein actually is widely open and there is no requirement for it. So there's actually no narrowing. So not only is there a positive prediction, and IVUS also can save a patient from actually getting a stent where a venogram shows you there is a narrowing. It may not be actually a narrowing, it may be an artifact or a spasm in a vein. So that is the value of an IVUS. Agreed, it's a high-tech thing, it costs, and everyone doesn't have access to it now, but that is something which is going to come into most vascular centers in the near future when costs come down and training improves. Now, a little bit about why I told you why do we talk so much about a narrowed iliac vein? Why do we need to? Why not just remove the clot and leave a vein? After all, there's contrast going up the iliac vein. No, the reason for that is sorry, there's a spelling mistake here. The Poiseuille's law. The Poiseuille's law. If you go back to your physics book, if you're talking about resistance to flow in a blood vessel, it's directly proportional to the length, and the viscosity, and inversely proportional to the fourth power of the radius. Now, obviously, for an iliac vein, we can't do anything about the length, but we can reduce the viscosity by giving anticoagulants and reducing the resistance to flow. But on the denominator side, if we can increase the radius, then we can significantly reduce the resistance to flow and reduce the venous, the venous hypertension. Therefore, in practically speaking terms, a twofold increase in the radius of the iliac vein will decrease the resistance by almost 16-fold. So the whole goal of opening the iliac vein is to reduce the pressure in the iliac vein so that it doesn't transmit downstream and cause a venous hypertension. So that is the reason why we all talk about now, treating a narrowed iliac vein. Has this venous stenting been studied, or is it a newfangled thing? No, it's been studied extensively. There are lots of trials. I don't want to go into the depth of it, but there are all the stents that are in the market have been studied extensively. There are trials which give very good patency rates and ulcer healing rates. Just to show you two pictures. Show you what a stent looks like in an iliac vein. In this case, you can see the patient has had a spinal surgery, DVT, post-thrombotic leg, bilateral leg ulcers, and we had to stent both his iliac veins. And you can see in your picture. This is another very gratifying picture that you've done a successful, good job. When I showed you this picture of an obstructed vein. And when you put in a stent, you can see that the collaterals had disappeared. Now, once the collaterals disappear, you fairly well opened the iliac venous system. And then post-stenting, we do an IVUS. And you can see this is the stent, and you can see the same stent which is narrow. So the IVUS actually helps us to evaluate how well you have stented it, whether there are any kinks which you need to iron out with a balloon. Now, when do you stent an iliac vein? Basically, a narrowing more than 50% is considered significant in a vein. So provided in your DVT cases, you are sure that there is no residual thrombus, you can safely stent the narrowed iliac vein. If you feel there is a residual thrombus, you would probably wait for a while for it to resolve and bring the patient back again for a further evaluation and a stenting. What is the protocol once you stent? Initially, heparin or low molecular weight, and then long term, of course, you need to just give antiplatelets to keep your stent open. Surveillance and aftercare post iliac vein treatment, you need to subject the patient to a color Doppler maybe every 6 months. But what is very important is that once you've deployed the stent, you should not forget the other components of the care, which is one, compression. You need to still put the patient on compression bandages if he has an ulcer, and you need to remember that the calf pump is actually the peripheral heart, so you need to strengthen that muscle to keep the venous drainage going with the help of good physiotherapy. So that is in a nutshell about post-thrombotic syndrome and how we actually manage these iliac vein lesions. Right. Thank you.
Thank you, sir. Thank you, sir. That was an enriching talk. We will go into the discussions now.
Yeah, please.
Yeah, there are a few queries in the chat box. One was whether immobilization is indicated. Dr. Tom, are you taking this?
Now recent guidelines are recommending against the immobilization. You can mobilize the patient after commencing the anticoagulation. Moderate level of ambulation is recommended after commencing the anticoagulation, and there is no need for strict bed rest as we advised earlier.
Can I add something? Probably the only contraindication would be not to give any passive massage, any sort of squeezing the calf, pressing, and Ayurvedic massages are not to be done in the initial phase. That would be the only. And people still tend, we can see that people still tend to restrict mobilization for the patient for longer days, weeks. They tell that don't walk. Actually, that Dr. Shekhar has told that the heart is in the calf muscle, so it has to move in for rapid resolution of symptoms.
Another question was on heparin, overlap with heparin and VK. When to stop heparin and depend only on VK? Whether you wait till INR is more than 2 or you keep it a fixed day.
We have to give heparin till INR is more than 2, and they are recommending ideally 5 days of heparin should be given even if INR is more than 2. Until INR is more than 2, we have to bridge with heparin.
If you could just add, it's just that, I mean, what was said is right. What I would add, one word is 2 consecutive INRs have to be on target. 2 consecutive INRs have to be on target. Yeah, so just don't depend on one report. Two consecutive INRs have to be in target. That's when you can stop the heparin and continue with your oral anticoagulants.
We also face across the problem of sometimes patients. No, the general practice, what I've seen among many specialists is to start with a very low dose of warfarin. Actually, the recommendations are to start with very high dose of warfarin, somewhere near to 7 or 10, and then scale down based on your INR. That's actually the recommendations. If I'm wrong, you can correct it, Dr. Shekhar.
Yeah,
Second thing is that this if warfarin is not producing or patient is not achieving target INR, you have an option of starting azithromycin or azinocumarol, wherein it seems to be much more potent drug, but you need to be more careful in this drug. The experience says that probably it overshoots a little bit more than warfarin.
Another question is regarding the prophylactic use of stockings in prevention of DVT, and then use of stockings after DVT diagnosis. Dr. Vimal?
Prophylaxis of I didn't get the question. I'm just searching the question.
Role of compression stockings in DVT prophylaxis.
Piloni TED stockings are actually adjuncts for DVT prophylaxis, but in mechanical prophylaxis, as per the risk criteria of the patient, the most significant thing is intermittent pneumatic compression machine. This TED stockings doesn't have much of a role. Then in post DVT scenario, can you repeat the question, Rajesh? I didn't get it.
Is graded stockings contraindicated in established DVT in view of thrombus dislodgement? That's a question.
Never. The only problem is that in an acute DVT, the patient might find it very difficult to get on a class 2 stockings. So it's a discomfort actually. So very often the practice is to give class 1 stockings in the initial phase. And then probably once the patient is comfortable and more, because very often you give a class 2 stockings in the initial phase, the measurement is for a larger size, and within 2 or 3 weeks you see that the class 2 stockings has to be replaced. So it's easier if you can give a class 1 stockings, is cheaper and less tight, and the patient is more comfortable, and then probably change to class 2 after the resolution of early edema and symptoms. Dr. Shekhar, anything to add on, please do.
Perfect. That's the most practical thing you have said.
Rajesh, I think the Gokul's question is 3-part question. They got 2 more questions attached to that particular chat. Can you just?
Yeah, I can see that first and second part. Can you give me?
No, distal DVT without risk factors can be followed up with surveillance without anticoagulation. Can we, maybe he's asking, can we follow distal DVT with only surveillance without anticoagulation?
The current evidence is actually in distal DVT, there is a school of thought that you need not, if patient doesn't have any risk factors, you can definitely put the patient without any anticoagulation, but definitely surveillance with ultrasound, Doppler ultrasound is indicated. Is there any time period to consider anticoagulants while on surveillance? Even if DVT is not progressing. If you're starting anticoagulation, I think they require it for minimum 3 months. I don't know whether it's something less than that.
And next question is very interesting. Is recanalization in duplex an indication to stop anticoagulation, or are we to continue up to 3 months or further in case of provoked DVT?
In a DVT, if I can answer that question, Rajesh, in a DVT, actually, if the patient is getting symptomatically better, I feel there is no indication to frequently do a Doppler assessment, because we see that every now and then the patient visits a consultant for DVT, every time a Doppler is ordered, and the different radiologists will give you different reports. So I think the end of 3 months, you're thinking of stopping anticoagulation, probably there is a role for reassessing the recanalization of the patency, probably yes.
Can I add 2 points to this question?
Yes, sir.
One is regarding the distal DVT with no risk factors. Now, as you correctly said, once you have a distal DVT and no risk factors, actually speaking, there is no indication for giving an anticoagulation, but you need a good surveillance, a good follow-up. So what is recommended is that you redo your duplex at 2 weeks, because about 15% will actually have propagation of clots, and those are the cases in which you need to start. Now the issue is the practicality of that. One, your patient has, you have to evaluate and see whether your patient is reliable to be coming back for a follow-up. If you feel your patient is unlikely to come for a follow-up, you explain to them that if you're not willing for a re-Doppler at 2 weeks, and there is a 15% chance that at that point in time your clot may have increased, that's when we start anticoagulation. So if he or she is clear on that and comes for a surveillance, well and good. Otherwise, practically what we do is that when we say there's a 15% chance that his clot is going to increase, patient says, no, I'd rather take the anticoagulation right from the beginning. That is one practical point. The third question is regarding recanalization. Do we still continue at 3 months? I think the ACCP guideline says a minimum of 3 months. There is no schedule less than 3 months. The upper limit will depend on a couple of issues. One is whether it's provoked or unprovoked. If it's provoked, then once your provocation is gone, say like a trauma or any kind of other issue, or say or oral contraceptive which has been given, then at 3 months, if your D-dimer levels are, and there are a couple of scoring systems also. So at 3 months, if your D-dimer levels become normal, then generally at 3 months, you need to evaluate the symptoms of the patient, evaluate the D-dimer levels, and see whether it's provoked or unprovoked. At 3 months, you need to decide whether you need to extend more. That is the time where probably you would, if it's an unprovoked, you would stop the anticoagulation and evaluate for a thrombophilic, workup to see. If a thrombophilia workup shows that there is some kind of a genetic defect like a protein C or some kind of a procoagulant state, that is when you would continue probably lifelong. There are also some, scoring systems like the modified Vienna scoring system. So if those of you who are interested can look it up, there are scoring systems to tell you, which you just feed in your data and it tells you what is the risk of getting the DVT back, and it helps to guide you whether you need to continue the anticoagulation or not. But generally, The bottom line is there is nothing less than 3 months. 3 months is the minimum you need to give. Even if the patient's symptoms have become okay in 6 weeks, still the minimum is 3 months. That is what the guideline says. Beyond 3 months is something you need to evaluate.
Thank you, Dr. Shekhar. I think, Rajesh, we have one question from Dr. Tony Thomas, who is a interventional cardiologist from Tiruvallur. He has asked whether an IVC filter is mandatory while giving. That's a private question to me. Probably I'll answer that. Mandatory while giving. Is an IVC filter mandatory while giving thrombolytic? He is a matchmate of mine. Probably that's why he sent a private question. Guidelines say that IVC filter is not at all required while doing a interventional procedure for DVT. That's a latest guideline or recommendations. Probably we overdo that, and probably for the theoretical possibility of a dislodgement of IVC, very often, of a clot, very often a filter is shoved in. But that's not required as per guidelines, if I am not mistaken.
With the permission of the chair, can I just make a comment?
Yes,
Yes. Nandan? Hi,
Yeah, it
Nandan.
is.
Yeah, welcome you.
Hey, excellent talks by everybody. Thank you very much. IVC filters, we used to put a lot of IVC filters in the past. And what we've learned is try and avoid them like the plague if you can. And you only put them in very strict indications, like it was mentioned, failure of anticoagulation or contraindications to anticoagulation. And when you put them in, put a date for removal. Even before you put it in, decide when you're going to take it out at its earliest. We have a lot of cases where the filter's been embedded. We've had difficulty taking it out, and the patient is left with chronic disabling pain. So IVC filters, I don't know what your practice is but we are trying to avoid them as much as possible. And our frequency of using IVC filters has gone down significantly now.
Yeah, the only practical issue which, when we discuss our cases is, most of these procedures are done in a prone position under local anesthesia, sometimes in places which are not absolutely perfect, ideal backup facilities, and you just need one patient of yours to crash to unnerve you. So while I would fully agree that, IVC filters, as far as possible, you try avoid it. But then, while doing these catheter directed procedures, as I said, one case which crashes on the table and you learned your lesson and you're forgetting your guidelines and, going back to the filter. That seems to be the issue in generally what I see.
Yeah, and Nandan, nice point. Can I just ask you one question? Suppose a patient comes to you with an IVC filter in situ which has been put 2-3 years back. Would you consider that patient for anticoagulation or not? He is actually not having active DVT or something, but the filter is in and you cannot take it out. So
No,
does that patient need to be on anticoagulation or not?
we have, Sunil, we have a bank of patients who with your scenario. Yeah. And I think Sid also has seen a couple of patients. One young girl, 22-year-old dancer, she comes in very frequently with back pain. They're not on anticoagulation. There is, as far as I'm aware, there is no data on it, but they get back pain. And we've done a few scans on her. Sid, do you remember the filter edges have actually come out of the IVC?
The IVCs in it. Yeah.
Correct. So Sid was on call when he received her once, and Sid and I were on call, and she comes in with back pain, and every time we are scared whether the IVC has poked through it has torn the cava, and we have in fact referred her, because venous surgery for the residents, it's not it's not the same as arterial surgery. So we've referred her even to centers where they do a lot of venous work, and interestingly, some of them have shoved in and taken out old filters, Sunil. And there is one place in London with one radiologist who actually does a lot of it. And he takes it out from the neck, and it's very brutal. And you're sometimes scared that he's going to tear the cava because it is all endothelialized. But he's pulled out 1 or 2 for us and failed in the rest. But we don't anticoagulate them. We've just left them. There's no science. Some of them we've left, some of them are on anticoagulation, but you could leave them either ways. Because if you remember, The indication to put the filter itself was failure of anticoagulation or contraindication to anticoagulation. So
if you go to the net, actually, you will find certain lawyers' sites who specialize in helping you with your litigation against IVC filters.
oh,
So there is a pool of patients who are victims of inappropriate filters. Many of these are actually permanent filters that have been put in.
Yeah. And so we've come up with a protocol. The day we book the filter, on the request, on the same day, we put the date for removal of the filter.
Absolutely. Yeah.
So the two procedures are booked. It's not one procedure. Date of indication. It's very interesting. And the topic of IVC filters itself is quite interesting a topic, I think. And that's what we do. We book date removal and date of thing. And the other thing is thrombolysis as well. As Shekhar actually pointed out, in theory, if it goes swimmingly well, it's an excellent one. But if things go wrong, I can guarantee you there are a lot of expert witnesses out there who will bring up evidence to show that it is not 100% effective procedure. And it is, in some centers, they actually advocate against it. And you will have an army against you. So when you do it, we have a protocol, send them up to HDU, monitor like their fibrinogen levels. We give heparin alongside, once you lace the thrombus, and we give lytic agents. We also give IV heparin, but strict monitoring. So make sure you have a time-tested protocol and you stick to that protocol. And one other thing that I'll add to everything else that you've said on the DVT, the one thing that you must do alongside everything else you do, simple thing, is elevation. And elevate the limb. It's not just with 2 pillows. Our patient goes like that. That's the leg end and that's the head end. So they are like that. And if you elevate that within 24, 48 hours, the swelling comes down dramatically. So don't forget, it's simple to do, but elevate the guys.
Shekhar sir, any experience with the newer, the thrombolyte, the mechanical devices like angiogen? How do you choose it versus CDT alone?
The thing with mechanical devices like angiojet is that they are conceived for a daycare procedure. So if you see most of the guys who do it overseas, patient comes in the morning, gets an angiojet, and the leg absolutely collapses like a balloon, deflated balloon, and by evening they are home. So most of our patients, the fantastic thing about these devices is that, one is for post-operative DVT. So you have a surgery, say you have done a prostatic tumor surgery, and the patient has, in the second post-op day, has a massive DVT. These mechanical devices, you don't need a thrombolytic because the clot is fresh. So you can just put it in and suck out everything, So you don't need a lytic. So that is one big advantage. The second thing is that clinically, it just deflates the leg and patient's symptoms are relieved, like magic, literally. So that is the issue. But the problem is that the costs, right? The costs are still prohibitive. And even in a setup like ours, we offer it to everyone, but probably out of 10 patients that we offer, probably only 2 or 3 would accept it. Majority of them would still find it expensive. That's a problem.
Timing is very important, isn't it? So do you consider an exclusion time like 2 weeks or 4 weeks like that?
With lytics, yes. I mean, if it's within 1 or 2 days, I don't even use lytics. If I use the angiojet, I don't use lytics, right? Because we need to consent them for a bleed. When you're giving lytics, we consent them for a bleed, whatever. Even if it's a smaller dose, the incidence of bleeding from other sites is not 0. So we put it down on paper that there is a risk of bleeding, which is why we keep you in the ICU and we closely monitor you. So, if it's early 1 or 2 days history and we find the clots are soft, you don't need a lytic. Up to 2 weeks is okay to do all these procedures. After 2 weeks, the results are, they steadily go down, and you might visually find that the clots are removed, but clinically your results are not that great because it's difficult to, actually remove every bit and piece of clot. So that's the issue. 2 weeks, up to 2 weeks is okay.
Beyond
Yeah,
3 weeks, you don't even put it on the menu.
Yeah.
One quick question, Shekhar sir, because what is the choice of anticoagulation in your practice? Is it some urokinase or the newer drugs like altiplase, teniplase?
See, if you go purely by data, the efficacy and the complication rates are both the same. The only difference between urokinase and actylase is that the speed of activity, right? The half-life for actylase is hardly 2 to 4 minutes. It acts much faster, but the efficacy is the same. And if you see the dose for urokinase versus the dose you require for actylase, so the costs are almost, it's not very much different. So there's not much to choose between the two, right? But in an arterial thrombosis, I would prefer actylase because you're having a limb ischemia and you want it quickly opened. Urokinase is slightly slower. In venous side, I think there's not much to choose between the two. Both are equally good.
Dr. Rajesh, I am Dr. Binny here.
Yeah.
I would like one of the panelists to explain regarding long segment superficial thrombophlebitis, superficial vein thrombosis, and axial junctional thrombosis, management of these things for the benefit of the audience.
Vimal?
Can you just repeat the question? The three scenarios, one is axial or junctional.
Long segment superficial vein thrombosis.
Okay.
Other one more than 5 centimeter, for example. Other one is the junctional thrombosis, saphenofemoral junction and some pop junction.
Yeah. Third one is superficial thrombophlebitis.
Superficial, long segment.
Short segment, long segment, and junction.
Yes, sir. See, the recommendations for superficial thrombophlebitis short segment would be to do a Doppler, confirm that it is away from the junction, at least more than 5 centimeter away from the junction, and you have an option for conservative management versus anticoagulation. But there is nearly 20% chance of a progression to DVT if it is close by the junction. Now, if it is a long segment phlebitis with a thrombosis near to the junction, the recommendations are to give fondaparinux at least for 45 days and repeat the duplex and see for any progression near to the junction. If there is a junctional progression, again, the recommendation is to initiate anticoagulation and plan for a venous ligation close to the junction.
Yeah.
Okay.
2 centimeter, I think 2 centimeter is the guideline, isn't it?
Yeah.
Okay, fine.
Another question I will have for Dr. Shekhar regarding generally for unprovoked DVT in young patient. In my practice, I wait for the anticoagulation to stop and then go for a prothrombotic workup, thrombophilic workup.
Yeah.
But with this NOACs or DOACs now being generally prescribed for anticoagulation, can you do it with this anticoagulant on?
No, the advantage of NOACs, DOACs is that you don't have to wait for it to get out of the system like you have to wait for warfarin. So you can do it earlier because, I mean, we have had catastrophic situations where we have stopped the anticoagulation pending a thrombophilia, and in the interim period, patient has got a massive VTE. You know,
Yes.
we've had at least 2 cases like that where the patient has come back to the A&E with a massive VTE. So the advantage for the NOACs is that you need to stop. That gap is much shorter. You know, so we just take the patient off for 2-3 days, maybe 2 days, and we send the sample and restart it.
Okay.
Can I just add something to that, sir?
Theoretically, we should be inhibiting this all protein C, protein S, or liver produce anticoagulant substances. Now, theoretically, they are not working on the liver; they are direct inhibitors. So, is there any theoretical explanation to stop this thing to test for thrombophilia?
What you're saying is that it doesn't actually suppress the clotting factors. So is there a scientific justification for stopping it? I don't know. They say there is some kind of interaction with the procedure for testing these, rather than the actual enzyme inhibition. There is some interaction with the process of testing it.
So in your practice, you stop for 2 days and then
Yeah,
send
48
them.
hours. For NOACS, it's just 2 days. Yeah.
Right. Thank you.
Can I add something with permission of Rajesh? My practice is when I have a patient admitted for acute DVT and it is an unprovoked DVT by history, pending basic malignancy screening, I would prefer to take the blood and send it for thrombophilia workup prior to the first dose of heparin. That's another option, whereby the risk of stopping, if you're giving the patient warfarin and or acetrom, and then at the end of 3 months, you need to stop it for 6 weeks or 4 weeks or 6 weeks, and then there's a risk of acute recurrence of DVT or a pulmonary embolism during that period. So my practice, I usually do it off if they are financially affordable. Anyway, they have to do it. So I do it off before the start of dose of anticoagulation is given.
There are 2 more questions here. Blood investigations in thrombophilia workup in early DVT. I think partially this answers that question.
Rajesh, one small comment. Actually, the latest guideline, Venous, are actually you need not do this workup in all patients with unprovoked DVT. Only if you have a first relative within some family history of hypercoagulable disease, then only you actually need to evaluate these patients. It's not a blanket recommendation now to investigate all these patients for procoagulant workup. That is one. Second is, if you are planning a genetic testing, there's no need to stop at all because genetics are not affected by NOACS. You only have to look for some factors which are being affected by coagulation, then only you need to actually stop them for 2 days when you're giving NOACS. Another thing, Vimal, when acute DVT, the levels of protein C, protein S might be little high or low. So you cannot actually take the sample at that point of time. That might give you a false low or false high protein C, protein S level. So that's not the ideal thing recommended. That's what is my understanding.
I agree with that.
Agree. Because Sunil, if I get a low protein C, protein S, I do repeat it later after stopping anticoagulation. I do agree. Regarding the first comment made by Sunil, the problem with it's a European guideline or a American guideline now. How many of our patients have had a real prothrombotic or thrombophilia workup in the family? If they had real need for it, our population hardly had many of the patients hardly had this workup. No, so to justify it that if your patient's family had a workup, only you need to do, probably we may need to wait for more time when more frequent tests are done. No,
you have to have a high index of suspicion also, say 2 extremities of age. Very young patient, unprovoked, you have to have a high index of suspicion that there is something wrong. Very elderly, unprovoked, you have to have a strong index of suspicion for a malignancy somewhere. Those 2 things need to be clear. Yeah.
There's one more question. What about pneumatic stockings in established DVT?
No, that's for prevention.
That's for
No.
Any more discussions?
One more new thing is that this homocystinuria or hystenemia, being folic acid, that has been taken off the procoagulant state. So there's new recommendation. There's no role for treating hyperhomocystinemia. That's the latest recommendation. That's in 2021 recommendation in the European Society of Vascular Surgery guidelines. So they are not taken off that. So you need not actually chase hyperhomocystinuria.
Yeah, generally, they say that in vegetarians the homocysteine levels are high. So unless it's abnormally high, we don't take cognizance of it. And if it's abnormally high, then we test for the HTFR mutation, MTFR mutation, which is the pre-stage of homocysteine. So there are genetic tests before you actually start folic acid. So merely on a raised homocysteine level, I don't think anymore it's recommended that you start on folic acid. If somebody has a homocysteine of say 80, 90, that's when you actually start working up, see if there is an enzyme defect. So MTHFR mutation is what you look for. And if that mutation is there, then there is a role of folic acid. Otherwise, routinely, merely on a raised homocysteine, I don't think there is really any indication for giving folic acid.
Shekhar, one comment on or a query on this. Your standard patients, what's your protocol for anticoagulation or antiplatelets?
For stented,
Post-stenting, iliac stenting, venous.
if it's post DVT, then your anticoagulation is till you are going to give it for the DVT, right?
The other group, the PTS group.
Yeah, the PTS group is a dead and buried disease, right? So for them, ecosprin is all that is required. You just require an antiplatelet, yeah. You need a large size stent. I mean, initially when we went into venous stenting, we were all putting in arterial stents and small size stents.
Yeah.
And we're getting thrombosis, and then we said, no, we should all start using anticoagulation. But the basic flaw in that management was that we were using the wrong types of stents and using very wrong size also. So if you use the right size stent and you use the right type of stent, probably aspirin is all that you require.
Siddharth, anything more on the quiz? Quiz is on, right?
Yeah, it's been posted, so I think the audience must have participated.
Okay.
Mr. Sir is there?
I think he has left. Sir. He's not there. So there is no more questions. Shall we wind up for today, sir?
Yeah, sure.
Yeah, we will wind up.
Rajesh sir, thank you so much for moderating today's session, the brilliant moderation. And all our speakers had put in very lucid and very clearly understandable thoughts on how DVT is managed, right from basic anticoagulation to complex interventions. And especially I thank Shekhar sir for taking his time today through his busy schedule to join us for this webinar. Thank you so much, sir. We also thank Serdia, who's today's sponsor for today's webinar. And big thanks to all of you participants for joining us today in good numbers, and also you're making the discussion very lively. Also, I invite all of you to join us for the next session, which will be in a couple of weeks. This will be on AV access for hemodialysis. Yeah, so thank you all once again, and have a good night. Thank you.
Thank you all. Thank you.
Thank you.
Thank you, Dr. Shekhar.
Thank you. Great.
Yep.
It's been a great session. Thank you.
Thank you, Binny sir. Thank you. Nandan is still there?
Vimal?
Sunil sir, yeah.
I am still here. Only thing is I was muted. So I was hearing the entire thing.
Usually you would put in some queries. I was just thinking why
No,
you are
I was just thinking, queries automatically come. Even today we had all the queries from a general surgeon's point of view was already there on the chat box.
Okay,
so
sir.
I thought, I just thought of just speaking like this at the end. That's why. Anyway, it was wonderful. I'm so happy that we have two vascular surgeons from our place, Kottayam Medical College, and both of them participated quite well. So thank you very much.
Thank you, sir.
Thank you.
Happy to be around. Have you around.
Sunil is there to monitor all of us,
Vimal, join us also. Although you're vascular, you're still doing some surgical work, I suppose. Join us on our webinars also.
Of course, sir. Thank you.
Thank you.
Thank you. Thank you all.
Bye, sir.
RC sir is left, I think. RC sir?
Yes, left. Thank you.
India, sir.